Hello, wonderful staff of the Northwest Kidney Center, particularly, of course, at the flagship unit in Kent. Today we're going to talk about the interpretation of monthly dialysis labs. And I'd like to thank Debbie at the Burien NKC unit for requesting this topic. So as you all know, the nephrology world loves numbers. We love to be able to quantify everything and anything, how well we're cleaning the blood, how good is the anemia control, how much fluid do we remove today, how happy are or how depressed are our patients, etc. So to this end, we check a lot of labs every month. Of course, we also survey our patients a lot, but that's a topic for a different discussion because today we're focusing on the interpretation of laboratory results. The objectives of today's talk are pretty straightforward. Um, want to be familiar with the labs routinely monitored in dialysis patients, know what the labs mean, how to interpret them, and why we check them. So this is a snapshot of the laboratory profile in our electronic medical record Clarity, and we'll discuss the labs in the order in which they appear. So we'll look at adequacy, hematology, common chemistries, liver disease, endocrine nutrition, etc. First, let's talk about the labs associated with the measurement of adequacy, or how adequately are we cleaning patients' blood during the dialysis procedure. BUN stands for blood urea nitrogen. It measures the amount of urea nitrogen in the blood. Urea nitrogen is a waste product that develops when your body breaks down protein in the foods that you eat. It's formed in the liver, and then it travels through your blood to your kidneys, which then filter it out of the blood. So it normally leaves the body in the form of urine. So you just pee it out, but of course dialysis patients lose the ability to make much urine, so it's predominantly removed by the dialysis procedure instead. The average pre-dialysis BUN is about 60 for dialysis patients. For patients who have normal kidney function, a normal BUN is less than 20. So it's elevated in the setting of kidney disease because the kidneys do not remove it well in the setting of end-stage renal disease. Now, BUN is not a particularly good estimator of overall kidney function or renal failure. So why do we check it every month? Because it is used to calculate something that is clinically useful called the urea reduction ratio, or the URR. So the urea reduction ratio is a formula that allows you to essentially calculate or quantify whether or not the dialysis is being performed with good quality. So basically the purpose is to measure how much urea is removed during a dialysis session, which is an estimation of how well we remove waste products. So how do we do the test? Basically we measure the BUN at the start of dialysis, and then we measure it again at the end of dialysis. And then there's a formula that we use. Basically, the urea reduction ratio is the pre-dialysis BUN minus the post-dialysis BUN divided by the pre-dialysis BUN, and that times 100, so you can express it as a percentage. So for example, let's say the BUN is 40 before dialysis and it's 20 after dialysis. The URR would be calculated as 40 minus 20 divided by 40 times 100%, and that equals 50%. So in this case, the URR would be 50%. Our target range for URR is greater than 65%, and it is a test that is measured monthly in our patients. Another way to assess the adequacy of dialysis is called KTOVERV. For some reason in Clarity, this is actually categorized at the bottom of the laboratory section under Z unknown. My birthday is in November, and if someone from Clarity is watching this video, for my birthday present this year, I'd like you to move KTOVERV estimation from that unknown section back up to the adequacy section, because it is a measure of adequacy. Okay, KTOVERV is a mathematical formula which has all these variables in it. K refers to the dialyzer clearance, specifically how much urea is completely removed from the blood in milliliters per minute. T is the time spent on dialysis in minutes. V stands for the total body fluid volume, and we know what the URR is. Again, that's the urea reduction ratio, which we just discussed. Ln is it's basically a mathematical term used to indicate the natural logarithm. So the upshot is that KTOVERV it was designed to determine how well dialysis is cleaning your blood. How do we do the test? Basically, for hemodialysis, we draw a blood sample at the start and end of the dialysis session, so that's the BUN like we talked about. And then we factor in like the dialysis duration, the volume of distribution, we take the natural log, and voila, we get a number at the end. For peritoneal dialysis, a blood sample is taken along with a sample of PD fluid, and the volume removed over 24 hours. So the target range for KTOVERV is greater than 1.2 in hemodialysis, and it's greater than 2.0 for peritoneal dialysis. It's performed once a month for hemodialysis patients and once every 3 months for peritoneal dialysis patients, or more often if there is a prescription change. If your KTOVERV and urea reduction ratio numbers are below the recommended levels, then the dialysis prescription needs to be modified, and there are several options. For starters, you can increase the duration or the time on dialysis. This can be logistically challenging because no patient wants to increase how long he or she is hooked up to the dialysis machine, and the patient's current dialysis schedule may not necessarily accommodate a longer treatment time. You can also increase the blood flow through the dialyzer. The more blood you process during the dialysis period, the cleaner the blood gets. You can increase the dialysate flow rate. That has less of an impact compared with time or the blood flow rate, but it's an option. And finally, you can evaluate the dialysis fistula to make sure there is no narrowing of the blood vessel that might cause something called recirculation, in which the blood that is already cleaned gets aspirated again by the arterial needle, usually because there's an outflow narrowing of the vein or a stenosis, making it harder for the blood to pass that narrowing. And if you process the same amount of blood over and over, then you don't clean the rest of the blood well. Okay, let's move on to the second part of the laboratory section in Clarity, and that is hematology. Every month, we check a complete blood count in our dialysis patients. There are 3 components to this test, basically the red blood cell count, the white blood cell count, and the platelet count. Hemoglobin is the primary test used in the dialysis world for evaluating anemia, or how many red blood cells are actually in the blood vessel. Hemoglobin is an iron-rich protein found inside of red blood cells, which gives them their unique red cover. It is primarily responsible for carrying oxygen from your lungs to the tissues and organs of your body. A hemoglobin test measures the volume of the protein hemoglobin found in your red blood cells. It's measured in grams per deciliter of blood. In dialysis patients, the target hemoglobin is between 10 and 11, although it's a fairly narrow range and it's often difficult to keep it within this target through the adjustment of Mircera. A normal hemoglobin, by the way, for someone with normal renal function is above 13 grams per deciliter. And we monitor it monthly during dialysis. Hematocrit is another way to assess the number of red blood cells in the bloodstream. It is defined as the percentage of the blood volume that is composed of red blood cells. So if you draw someone's blood in a vial and you spin it down, then all the red blood cells fall to the bottom and the plasma rises to the top. And the percentage of the red blood cells that comprises the total blood volume is your hematocrit. It is part of the complete blood count, and the target for a dialysis patient is between 30 and 33%, although the accuracy of measurement can be affected by volume overload. So for example, if you have a lot of extra fluid in the blood vessels, as is common with dialysis patients, this can artificially lower the hematocrit and make the anemia seem worse than it is. Similarly, if a patient becomes dehydrated, then the hematocrit can overestimate the actual level of red blood cells. We have 2 different tests to evaluate anemia, hemoglobin and hematocrit, and they correlate well with each other. But in the nephrology world, we prefer to use hemoglobin. Why is this? Well, the short version is that hemoglobin, the assay to measure it, is more accurate than the method by which we measure hematocrit. So there's just less variation in results. You get greater accuracy, greater reproducibility between labs. So we use hemoglobin to determine are protocols for administration of Mircera as well as iron. The CBC also reports something called the mean corpuscular volume, or MCV. This measures the average size of your red blood cells. If the MCV is low, say less than 80 microns in diameter, these red blood cells are smaller than normal, and this can be seen in the setting of iron deficiency, although there are other causes as well, such as lead poisoning and a genetic disorder known as thalassemia. High MCV means that the red blood cells are larger than normal. Most commonly, this is seen in liver disease, B12 deficiency, folate deficiency, as well as something called reticulocytosis, basically the generation of lots of young red blood cells. If you have a dialysis patient who's new to dialysis, you give them lots of Mircera and iron, they'll start cranking out lots of young red blood cells, and young red blood cells are called reticulocytes, and they are larger than older red blood cells. The CBC also measures something called the white blood cell count, basically how many white blood cells we have in our circulation. There are 5 major types of white blood cells. These include neutrophils, lymphocytes, eosinophils, monocytes, and basophils. They all have different roles in terms of protecting us from infection and dealing with infected cells. Normal range is 4 to 11,000 cells per microliter. Low white blood cell counts are often seen in infection or autoimmune disorders such as lupus, bone marrow disorders. Medications such as antibiotics can cause it, as well as toxins such as alcohol. High white blood cell counts are concerning for infection, but stress or other illness or cancer can also raise the white blood cell count. CBC also includes something called a platelet count. This measures the number of platelets in your blood. Platelets are pieces of cells that help your blood clot. A normal platelet count is typically between 150,000 to 450,000 particles per microliter of blood. If it's high, say greater than 450,000, we call that thrombocytosis, and that could be a bone marrow problem or could be secondary to an underlying problem such as iron deficiency or an infection or cancer. If it's low, say less than 150,000, we call that thrombocytopenia, and lots of things can do that, including medications, cancer, toxins such as alcohol. As an aside, certain medications inhibit the function of platelets and increase the risk of bleeding. These include aspirin, as well as a medication called clopidogrel or Plavix. Many of our patients take these medicines, and these are the patients who oftentimes require longer to clot at the end of dialysis after we remove the needles from their dialysis access. Another useful test in management of anemia is iron saturation or transferrin saturation. This test measures the amount of iron bound to a protein in the blood called transferrin. Transferrin is a protein that binds to and transports iron in the blood. If not very much iron is bound to the transferrin, that suggests iron deficiency. So in other words, if you have a low iron saturation, then they don't have a lot of free iron in their blood to make red blood cells. If it's less than 20%, we administer intravenous iron to our dialysis patients. Turns out that dialysis patients need a lot of iron in order to make new red blood cells and respond to Mircera. Another important test for estimating iron stores is called ferritin. Ferritin is a protein in the blood which binds to iron and assists in its storage. Think about your body as a kitchen pantry. Most of the pantry is stocked with foods that you use every day, but sometimes there are some items in there that are there for a rainy day, an extra box of pasta or a can of beans that you have when supplies grow low. Your body stores iron the same way. Basically, it uses some of the iron it gets from food right away to make hemoglobin, but it also has some iron stored inside of cells for times when you don't get enough through your diet. The iron is stored inside of cells attached to this protein called ferritin. And while iron saturation is a good estimation of the blood level of iron, the ferritin level is a good estimation of the body's total body iron stores, or how much you have essentially in the kitchen pantry. Low level of iron is consistent with iron deficiency. We used to administer iron on the basis of a low ferritin and low iron saturation, but the current NKC protocol just bases it on the transferrin saturation. Okay, moving down the list, let's now talk about common chemistries. We measure common chemistries in our dialysis patients every month. These include sodium, potassium chloride, bicarbonate, calcium, and phosphorus. Every month we measure the sodium concentration in the blood of our patients. And notice how I use the word concentration. Um, We're measuring a certain amount of sodium by weight divided by a certain volume of water in the blood. A lot of times patients see their sodium test result and assume that a low value means they don't have enough salt in their body and a high value means they have salt excess, but in reality, neither is correct. The amount of water in the blood is the main determinant of the sodium concentration in the blood. If a patient drinks a lot of water, it dilutes the sodium concentration in the blood and therefore lowers it. For a dialysis patient, the serum sodium concentration usually runs between 135 and 140 millimoles per liter, but often runs lower in dialysis patients who drink a lot of water. So for example, if you have a dialysis patient with a really low serum sodium concentration, say 125 millimoles per liter, you know that they drink way too much water. The problem with a low sodium concentration in the blood is that the sodium will diffuse into the patient during dialysis if the concentration of sodium in the dialysate is lower. Concentration of sodium in the blood is lower than that of the dialysate, and this will raise the patient's blood pressure and make him or her thirsty and more likely to drink water. So essentially, it's a vicious cycle that leads to volume overload. A normal pre-dialysis potassium for a dialysis patient is about 4 to 5 millimoles per liter. Pre-dialysis potassium levels are important for choosing the proper dialysate potassium concentration. In general, we use a 2K bath if the serum potassium concentration is between 4.5 and 5.9 millimoles per liter, and a 3K bath if it's less than 4.5. A 1K bath is rarely used these days because it's associated with intradialytic and post-dialysis hypokalemia or low potassium concentrations. These can trigger arrhythmias and are associated with an increased risk of sudden cardiac death. The monthly serum chemistry panel also includes something called bicarbonate. Bicarbonate is the main form of CO2 or carbon dioxide in the blood. CO2 is generated in your tissues from aerobic respiration, then travels in the blood in the form of bicarbonate to your lungs, where it's exhaled in the form of carbon dioxide. So the body constantly generates acid waste products, which are normally removed from the blood by the kidneys, and these accumulate in dialysis patients. That's why we give dialysis patients bicarbonate during their treatment to help neutralize the acidity of their blood. Ideally, we want their pre-dialysis carbon dioxide level or bicarbonate level to be around 22 millimoles per liter. Higher levels are associated with an increased risk of hypokalemia and cardiac arrhythmias, and lower levels mean more acid in the blood, which leads to a weakening of the bone because you absorb phosphorus from the bones as another way to buffer the acid in the blood. And acid is also bad for the cells in your bone called osteoblasts that help make new bones. We also measure calcium monthly, and you all know everything about calcium because we covered it in a recent in-service, but just by way of review, calcium, of course, is a very important mineral found throughout the body, has many functions. It's important for forming strong bones and teeth. It's important for proper muscle function as well as nerve function, helps to form blood clots, regulates cell activities, secretion, cell division, multiplication. It's important for enzymatic reactions as well. Comes from our diet. So dairy products, green vegetables, eggs, things like that. And calcium is carried in the blood. And the blood calcium level is highly regulated so that the body works properly. And that's done by a hormone called PTH, or parathyroid hormone, which we'll discuss momentarily. A normal calcium level for a dialysis patient is around 8.5, 10.2. High blood calcium levels are bad. Specifically, they increase the risk of developing vascular calcification or calcium deposition of the walls of blood vessels, or so-called hardening of the arteries. Phosphorus is another mineral in the body, and together with calcium makes up most of our bones. Like calcium, phosphorus is used in other parts of our body to power muscle in the form of ATP. It's used in many other chemical reactions. Phosphorus gets in our Body by way of food, such as dairy products, nuts, and meat. Normal phosphorus level for someone who's not on dialysis is between 3 and 3.5, and ideally for a dialysis patient, we keep it below 5.5 millimoles per liter. Similar to calcium, high phosphorus levels have been shown to trigger the calcification of blood vessels. So it's very important to control phosphorus levels in order to maintain the health of our vascular system. In other words, the main reason why we work to lower phosphorus in our dialysis patients is to keep their blood vessels healthy. An important regulator of calcium and phosphorus levels is a hormone called parathyroid hormone, or PTH. Basically, it's a chemical messenger which is produced by four small glands in the neck called parathyroid glands. Each is really tiny, size of a pinhead or a pea. Basically, they're found in the neck behind the thyroid gland. So incidentally, these glands are right next to the thyroid gland, but have completely different function from the thyroid gland. They just happen to be next to each other. Now, if the level of calcium in the blood falls, then the parathyroid glands normally produce more PTH, which pulls some calcium from the bones into the blood, normalizing the level. In contrast, if the calcium level in the blood rises above normal, then the PTH secretion falls and the level of calcium in the blood falls back to normal. The normal range for PTH depends on the technique used by an individual laboratory, but for dialysis patients, generally between 150 and 400 milliliters per minute. There are a couple of medicines that are used often to lower PTH in dialysis patients. These include Zemplar or Paracalcitol, which we administer on dialysis, as well as Cinacalcet, also known as Sensipar. Okay, let's move on to the next section in the Clarity Lab section, liver studies. So hepatitis B, we check for hepatitis B twice yearly if immune, so if someone has antibodies that are present, or if they are non-immune, we check their hepatitis B surface antigen monthly. So hepatitis B surface antigen is a serologic hallmark of HBV infection. Basically, it can be detected using an enzyme immunoassay, and it appears 1 to 10 weeks after initial acute exposure to hepatitis B. If the person is able to clear the infection, then the hepatitis B surface antigen typically resolves. It goes away after 3 to 6 months. On the other hand, if the infection persists, then so does the presence of the hepatitis B surface antigen. Unfortunately, with this test, there are some potential false positive results. In other words, the test is positive, but they don't really have hepatitis B. Good example that we see all the time in dialysis units is recent hepatitis B vaccination. So the vaccine consists of hepatitis B surface antigen, so we give it to the patient in order to stimulate an immune response. But of course, if we give them the antigen, then they're going to test positive for the antigen. Other viral infections, such as Epstein-Barr virus, have been associated with false positive hepatitis B surface antigen tests. Now, in contrast, hepatitis B surface antibody is a serologic hallmark of immunity to hepatitis B, either from vaccine or from prior infection that say has resolved. Now, how can you tell if a patient with hepatitis B surface antibody was previously infected? Well, as opposed to just receiving the vaccine. Well, you can check a hepatitis B core antibody. And if that's present, either they were previously infected or they have a current hepatitis B infection. Now, if the hepatitis B antibody remains undetectable despite vaccination, then we consider them to be non-responders. And that's about 30 to 40% of dialysis patients. And then we check their hepatitis B surface antigen monthly. We also screen our dialysis patients for hepatitis C. Specifically, we check for hepatitis C antibody. And a positive test means that you've been previously exposed to hepatitis C. You could have chronic infection or you may have cleared the infection. But once you've been exposed to hepatitis C, you'll have a positive antibody test for the rest of your life. If you need to know if someone has active versus former infection, you can screen them for the presence of hepatitis C RNA. If it's positive, then they have active infection. All right, we're moving right along. The next section is the endocrine and nutrition tests in Clarity. We often measure the hemoglobin A1C in our dialysis patients. It's also called the glycosylated hemoglobin test, whose purpose is to estimate the average blood sugar level over a 3-month period in diabetic patients. The test measures the percentage of red blood cells in the blood that have become glycosylated, that is, have undergone the addition or the attachment of a glucose molecule. The higher the blood sugar, the more likely it is that a sugar molecule or moiety will get attached to the glucose molecule, the higher the hemoglobin A1C. So an elevated hemoglobin A1C reflects worse sugar control. The goal is a hemoglobin A1C of less than 7%. But in dialysis patients, unfortunately, the hemoglobin A1C is a relatively inaccurate estimate of glycemic control. The main reason is the shortened red blood cell lifespan in dialysis patients. Red blood cells typically last about 120 days. It's about half of that, or maybe 60 to 70 days in a dialysis patient. So if you have a higher red blood cell turnover, then the hemoglobin molecules that had the glucose molecule attached to them, get recycled, and so you underestimate the real hemoglobin A1C value. Same thing if we lose blood with a dialysis procedure, or if we give blood to a patient in the form of transfusion. And then finally, there is some concern that an elevated BUN and metabolic acidosis can interfere with the accuracy of the assay in measuring hemoglobin A1C. So, in short, tends to underappreciate elevations in glucose in the dialysis population. We also measure albumin on a monthly basis in our dialysis patients. It's derived from the Latin word albumen, which means dry egg white, and so even the Romans knew that eggs were a good source of protein. Albumin is produced by the liver, and it constitutes about 60% of the proteins in the blood, so it's a predominant protein that exists in circulation. We know that low albumin is a predictor of protein malnutrition. It's also a marker of increased mortality. So dialysis patients with low albumin have a much higher rate of hospitalization, increased mortality compared to those with normal albumin. Why is this? The main reason is that albumin is also an acute phase reactant protein. So there are certain proteins that are either overproduced or underproduced in the setting of acute illness or acute inflammation. So for example, positive acute phase reactants include the erythrocyte sedimentation rate, C-reactive protein, fibrinogen, and ferritin. So when your body is stressed out, the liver cranks out more of these proteins. On the other hand, when the body is really sick, you produce less transferrin saturin and albumin. So albumin is a negative acute phase reactant. So its levels plummet in the setting of acute illness. And therein lies its clinical significance. So if a patient has a low albumin level or it falls precipitously, it's usually because they're sick rather than they're not eating much, although the two often go hand in hand. Okay, time to summarize what we've learned. First, BUN is a marker of protein metabolism. The main significance is it allows us to calculate the urea reduction ratio. KTOVERV is another marker, so dialysis adequacy relies on the urea reduction ratio, the treatment duration, patient's body weight. Hemoglobin is our main measure of red blood cell production and how we monitor anemia. We monitor the white blood cell count particularly as a screen for infection, although it can tip us off to other problems, including cancer. Transferrin saturation is the amount of iron bound to a protein in the blood called transferrin. Lets us know how much iron you have in your blood immediately for use. Ferritin is a better estimate of the body's total stores of iron. Sodium concentration primarily reflects how much water our patients drink. So if someone comes in with a low sodium concentration, it's because they drank too much water, not because they don't have enough sodium in their blood. Ideally, we keep the potassium between 4 and 5. You want to avoid either low potassium or high potassium because of the risk of arrhythmias, which is why we rarely use the 1K dialysate baths. Bicarbonate is the main form of CO2 in the blood, and we administer it to our patients to neutralize the acidity. Ideal pre-dialysis level is 22. Higher levels are predispose our patients towards arrhythmias, and lower levels are bad for our bones. Keep the calcium between 8.5 and 10.2. Higher levels contribute to vascular calcification. Same is true with phosphorus levels. High phosphorus contributes to calcification of blood vessels. Parathyroid hormone is involved in the maintenance of a normal calcium level, and you have really high levels that can lead to bone problems. Hepatitis B surface antigen is a hallmark of active hepatitis B disease. whereas hepatitis B is a marker of immunity. Hepatitis C antibody is present if you've been previously exposed to hepatitis C, even if the infection has gone away. Hemoglobin A1C is a relatively poor marker of glycemic control in dialysis patients. Albumin is a poor marker of nutritionist because it's primarily a negative inflammatory marker, so levels go down when you are sick. Okay, let's take a quiz. Question number 1, serum sodium concentration in a dialysis patient is low at 122 millimoles per liter. Should we give this patient sodium or encourage sodium intake? The answer is no. Just remember that serum sodium concentration is low in this case because of the excess of water. Water dilutes out the sodium concentration in the blood. So if you see a hyponatremic patient on dialysis, do not encourage them to eat more salt. Question number 2, what test do we use to decide if a patient needs intravenous iron? That's right, the transferrin saturation. So we administer intravenous iron if the level goes below 20%. Again, transferrin saturation is a good marker of the iron levels in the blood that are immediately available for red blood cell production. Question number 3, a patient has both a positive hepatitis B surface antigen as well as core antibody. Does he have hepatitis B infection or is he immune? That's right. This is chronic infection. Remember that if someone has hepatitis B surface antigen, that is a hallmark of active hepatitis B infection. Hepatitis B core antibody, not surface antibody, but core antibody is always positive if someone has been previously exposed to hepatitis B, even if the infection resolves. Question number 4. A diabetic dialysis patient has a hemoglobin A1C of less than 7%. Is her diabetes control good? So recall that hemoglobin A1C is not a very accurate test in the estimation of average glycemic control. Because of the shortened red blood cell lifespan, it falsely lowers the percentage of red blood cells to which a sugar molecule has become attached. Final question. A dialysis patient is released from the hospital and has an serum albumin of 2.3 grams per deciliter. What is the main cause of the low albumin level? That's right, inflammation. So recall that albumin is a negative acute phase reactant protein, meaning that the liver makes less of it when the body is sick and inflamed. So low albumin levels in acutely ill patients generally reflect inflammation rather than poor nutrition, although as I said earlier, those two can go hand in hand. This concludes the March 2023 in-service for the Northwest Kidney Center. Thank you all for your attention, and thank you for being so wonderful and providing such excellent care to our patients. This is Andy Brokenbrough signing out until next month. Have a great day.